We have half an hour left, guys. Nobody's listening to me, are they? I have to get the bell out. Okay. I am determined to get you away on time, if not slightly early. I don't know if that motivates anybody. Okay. So, what I want to do is I want to get each table facilitator just to give us a brief summary of the kind of themes that came up, and maybe one or two examples of some of the statements that they wrote, success sort of statements, some of the ideas they've had and what they think DCAN can do. But please keep it really short. We've got 8 tables to do, and you do want to go home, don't you? So I picked on Ian to start first, just because, you know, I thought that would be a good thing to do. So he's got a mic, and then I'll probably just go round the room like that, which means you guys get to go last in supported self-management. Okay?
Okay. Is this microphone on? Yeah.
Yeah.
Okay, our group was looking at personalised care and support planning. We had a massive discussion looking at all different angles, and we prioritised these 3 themes. So one was about the importance of seeing the whole person. So personalised care and support planning doesn't happen unless that's the fundamental. In achieving that, there's massive learning gaps. There's learning gaps for people and carers in terms of knowing what rights and entitlements are, even understanding about personalised care or the tools and kinds of questions and conversations that are possible. And also massive learning gaps from health professionals in terms of giving people the time, the space, knowledge of good personalised care and good practice, but also knowledge about how to do that well with people with different dementias, different stages of dementias. And the third area, particularly looking at the system, was the difficulty people have in terms of making sure that information can be shared easily and simply, and that there aren't barriers around data protection or just the practicalities of keeping complex whole life plans for such conditions that can be as expensive and as so many professionals involved as dementia, how you make that process painless and seamless were the biggest issues. So flipping all that on its head, people and carers, the statements we came up with was about knowing rights and entitlements to personalised care, know how to get a care and support plan, that carers are seen as distinct but also connected to the person and that may be entitled to their own care plans as well. The workforce are able to access information they need at the time they need it, so there's a big discussion about why get all this information if carers and professionals aren't actually making practical use of it. We're confident at having a good conversation, so making sure people know how to do this stuff, have time to practice under pressure, but are also expected to engage and improve the process over time. And the system was about taking away barriers, putting in place incentives, making sure that excuses in the system of why things aren't happening isn't the mindset. It's more about, okay, that's an issue, that's a problem, how do we work together to overcome that practically? Achieving this is making sure there's documentation, information, support available to people with dementia as well as the workforce, and that there's alignment across the system, that everyone's using the same language and similar approaches. Very quickly, because I know I'm going on again. But in terms of DCAN, it seemed very much, one of the interesting ones actually we hadn't thought of particularly before articulated in this way, was to give voice and emphasis nationally on rarer types of dementia that maybe at a local level there's so few people experiencing that type of dementia that there's very little time or space given to them, but on a national perspective we can get those views and voices heard. But looking around, looking at creating space to understand what gets in the way, listening to people, trying to find economies of scale. So a lot of this change will have to happen at individual, local and system level, but where we can actually pull knowledge, resources and tools at a national level to facilitate a lot of that work and make things more coherent. That was all part of it. Okay, I shall stop there.
Thank you very much. So I'm going to go on to this table here, Gemma.
Yes, thank you. We were a bit more streamlined over here, hence not as many post-it notes. So we also were personalised care and support planning. Actually not too dissimilar, there's a lot of discussion by the sounds of things that we had on our table. We looked at 3 key areas. So one was around how our I statement was around I co-produce and own my own PCSP and are enabled to use it, share it with everybody who needs to see it. And it enables me, and this was the key bit for us, to live well now and meet future wishes. And one of our big discussions was around doing this much earlier in somebody's journey from diagnosis. So we talked a lot about that. We talked a lot about making, again, knowledge, skills and confidence of workforce to be able to have these conversations and to have a really good personalised care and support plan for people with dementia. And then for the system, again, it was around making sure that there is a standardisation across the whole country around personalised care and support planning, so that it's standardised, people know what should be expected and what everybody should be delivering from a system perspective. So we've said we're going to achieve this through lots of different ways, but essentially by embedding this, creating some, the standards, the system supporting that. And then we actually gave DCAN a lot of things to do. So we were quite action focused. And one of the things that we really see DCAN is to be able to bring a lot of this intelligence together. So one of the things that we said is that we know there are lots of tools out there already around good personalised care and support planning, not only for people with dementia, but generally. Let's do some mapping. We've renamed ourselves the mapping group. So we want to do some mapping around actually what's out there now. Does it meet the standards? And if it does, then what can we do to be able to kind of promote that, to share that, to say actually this really works. We also think there needs to be some work around training as well, and looking around working with Skills for Health and Health Education England. I'm looking at my colleagues over here to look at how we embed PCSP training for people with dementia. And then finally, again, another piece of mapping was around looking at the systems, looking at how systems are delivering personalised care and support planning. We had big conversations around who is the best person to be doing this, and in what part of the system. Is it in primary care? Is it in community settings? Is it, we didn't know, and we said that actually, as DCAN, can we put a shout out to potentially primary care networks or local systems to say we'd be really interested to understand how you're delivering this locally, or actually can we play about with you with this? Can we pilot something with you? Can we work with you to understand maybe the different ways that this could be delivered? Thank you.
Okay, over to me. Thanks. I'll shift over here so I can see. So we had the social prescribing table, one of them, because there are 2 of us. And as you can see, we had a very rich discussion. So looking from the perspective of people or carers, there were some really kind of clear things that came out from us and some strong consensus in the table, one of which is people knowing about social prescribing to begin with, how they can access it and how they can benefit from it. And then another really important point was people having access to social prescribing as soon as possible, either with a memory assessment or at point of referral. And that was really kind of strongly articulated from a number of people in the group, that it can't come early enough and too many people are having to wait far too long for that referral. And then linked to that is there being help when people need it, and equity of access, and you'll not be surprised at the words postcode lottery. We're brought up a number of times, but obviously the schemes vary from area to area, and there's lots to be done to make sure that that is equitable for people. And another point was about people accessing information, accessing social prescribing at any time as needed, and it's been, in particular people with dementia, their needs kind of change, so that was quite important. And then we wanted to also emphasise the point that social prescribing isn't just for people with dementia, it also should be available for their carers and for their family members as well. From the workforce perspective, I think it was obviously training and skills came up an awful lot, and making sure that all relevant areas of the workforce were dementia aware and they had the relevant skills and training. And then also that people knew where social prescribing fits into the pathway, and that it's embedded as part of that, which Gemma will be very pleased to hear about. And another important point was about GPs and clinicians and others seeing well-being as important as physical health as well, so there's a bit of a culture shift to be had there. And then on the system kind of perspective, we need to, it's all very well having link workers and social prescribing schemes in place, but there needs to be things for people to be referred to and a diverse range of provision, including peer support. And there's also work to be done at a system level around integration and organisations working closely together and sharing of information and better use of tech, which I was pleased with. And then we had loads and loads of ideas on how we kind of achieve this, but I'm going to skip, in the interest of time, to what we think DCAN can do. But there was a very kind of clear role for DCAN, we thought, in terms of setting the standards about what good looks like and making sure that that's widely communicated. There's a whole range of organisations that have committed to DCAN, and we need to make best use of that voice, really. And we also thought there was something about us making the case for the importance for social prescribing for people with memory loss as well, and why that's important. We thought we could do something kind of professional and system-facing, communicating value for money and the impact that has on people's lives. And then the softer side of that is collecting some case studies and stories about the difference that it's made. And Sharon knows, am I getting a signal? Shall I hurry up, Joe? Sorry. And then we also kind of quite wanted to do something public-facing around improving kind of public information and awareness about social prescribing, so potentially a booklet, which I probably can't remember the name, but it was something about keeping well and staying connected to your community as well, so people know that exists. And Dementia Friends came up a lot, and how we can kind of make better use of Dementia Friends, both in terms of Dementia Friends training for link workers, and doing a bit of an assessment in terms of how many currently are trained and making sure that we can increase that, but also making sure that social prescribing is referenced as part of Dementia Friends training, so anyone can become a Dementia Friend, but in that whole interest of raising awareness, that it becomes part of the Dementia Friends aspect. And that's all from me. Thank you.
Somebody was ringing me, that's what it was. Okay, so our second social prescribing group, that would be Fab.
This is the second group. I'll be quick because actually we agree with everything that Laura's just said. And we covered a lot of similar ground, actually. Picking up the issue around access and empowerment and choice. One of the things that we picked up was that actually it changes through the journey of someone living with dementia. And actually there's an awful lot of demands on link workers to do all sorts of different things. And sometimes they'll need to bring someone in from maybe a Dementia Alliance to help with those choices, to be part of the consultation or meeting that you have with someone that needs some support in developing their health and well-being plans. So that was a very important point. That parity of access for someone over the journey of dementia is really important. But we also picked up on the point that it needs to happen early in someone's dementia journey as well. The second area was around knowledge and skills. And again, the link worker, if you look at the job description, I know many of you have, it's extremely demanding in terms of a job. They're seeing 200 to 250 people a year. They're expected to do community development activities, link up with voluntary community organisations, get involved in quality assurance and so on and so on. So it's an extremely busy and demanding job, and we can't expect them to have the skills and knowledge to do everything. So again, it's about making sure that link workers have the knowledge around dementia, but connect to the right people in their communities that can help them. And I think the quickest fix around this is to actually connect with the dementia groups in the local area, dementia-friendly communities and so on, to make sure that they've got a good support network so they can promote social prescribing and they can learn about the needs and the wants of people with dementia. And the last point was around the system, and we had a number of requests today for me to mention something about social care and the perceived lack of social care involvement in social prescribing and and dementia. And I think I know for sure that there's very little research with regards social care and the impact of social prescribing. So I think that's something that DCAN could actually promote. It's very necessary, but most of the research seems to be coming through the health service and health outcomes in terms of hospital admissions and so on, which is of course very important because that's where the funding's coming from for new link workers. But social care impact is also very important. So I think any new research that could be funded to do some investigation into that area would be most useful, as it would also be very useful for a better engagement with social care nationally and locally. Okay, thank you.
Okay, Stephen, you doing
Thanks,
personal
Joe.
health budgets?
Thanks, Joe. I'm feeding back for the personal health budgets table, and I've already got the wrong glasses on. How's that? I won't be able to read that. Sorry about this. We had a comprehensive, wide-ranging discussion on all aspects of personal health budgets and people's experience of dementia care services, but I'll try to be brief, and I hope I do it justice because I worked with a lovely group of people who had lots to contribute to this, so I do apologize if it's really brief for those who worked really hard on the table. For people in carers, we started off with the statement that I feel involved, listened to, and respected, and I feel in control of the care I need. Working with professionals, I know what I have a right to access. So that was the statement for people in carers. Now we've come up with a lot of post-it notes, and you don't see them many more on the other side here on the other board, so I'll only pick one or two. So to help achieve that, how we can achieve that is, my care plan reflects what I need in my PHB as one of them, and another might be my contract shows all the choices I have made, have been reflected in my care and support plan. In terms of workforce, the I statement we came up with is, I am trained to feel, this is for workforce, I feel trained to feel confident in how to access and refer people to PHBs. So the professional has a really good understanding of processes and PHBs themselves. And how can we achieve this? We have a lot to choose from here. Regular review of skills, training for staff. We talked about patient satisfaction surveys. We talked about I have access to clear guidance and on how PHBs can be accessed and so on. And in terms of the system, the ICE statement we came up with is, I feel able to navigate an integrated system that is proactive in providing support. And how can we achieve that? Again, we came up with lots of ideas of how we can achieve that. For example, a named case manager, sorry for my back here, Sally, named case manager for access to the PHB and to navigate someone through the whole PHB process, so there's consistency there. Providing paper copies of records, just to explain, because we've gone so electronic now with things that people don't often get paper copies. And we have an example where even in someone's own home, sometimes there aren't any paper records anymore. And so it's very difficult for people to access records because it's all electronic. And also perhaps a menu or a crib sheet, where to seek support, and recovery approaches that could be used with PHBs. So that's the first two levels. Now in terms of what DCAN can do, I'm afraid we came up with lots of things that DCAN do. We'll keep them busy for decades to come in terms of the work that we want them to do. So in terms of people in carers, we said, sign them up to make it real, making it real. We thought that would be really great for them to join and sign up to that, to lobby and to influence government, Department of Health, and other large organizations, because it's very difficult for some of us in statutory services to be political and to push the agenda for PHBs and personalised care. So DCAN might be in a very good position to lobby on behalf of dementia services, including the APPG group, which is the all-party parliamentary group, and raising awareness. And a really good example that came up, do you don't mind if I try to explain it? Perhaps we need someone in a soap opera. This was a character we thought maybe EastEnders, Dot's in EastEnders? Yeah, we thought maybe Dot could have memory problems and then Nick could come back. And I'm not saying he'd be the PA or the budget holder, because that might be a bit of a risk to have Nick as the budget holder. But you know, an example in a popular TV series would really help raise awareness for us in terms of personal health budgets, if Dot could have a personal health budget. And for the system, for DCAN, we thought that DCAN could perhaps collect successful case studies for us. We're always looking for case studies in the personalized care group, and the DCAN could really help us to find really good case studies where people are using PHBs to manage their own care and support where they can when they have dementia. Because it's not a cohort that's specifically named, so this might help us in that regard to have more case studies. And we also thought that DCAN could help with mapping best local practice, and I'll just pick one more. Act as a watchdog, perhaps looking at consistency to avoid postcode lottery in terms of how personal health budgets are rolled out and which cohorts can access them. That's my brief summary.
Okay, you three have got to be really brief because we've only got 8 minutes. Okay, choice.
Can anybody hear me? That's great. Okay, sorry, can I pull this round so people can see? I do apologise. Right, okay, I'll just read over the top. We've got the statements. First one is for people and carers, and with respect to... First one is with regards to choice, and it's for people and carers. I'll just read it out. It says, we are enabled to talk about funding, legal matters and options early on and before diagnosis, so we can plan for our health and social care needs being met in ways that we feel are appropriate to us. So that includes, you know, deciding on power of attorney. The actions to support this included making sure that the financial and legal information, the provision of that was given at health check stage, or even at the point of obtaining a mortgage, for example. And another example of supporting this will be the GP surgery to act as a hub, not necessarily having the GP as a point of contact, but just having someone in there to do that. And for DCAN, the actions are to encourage, enable, ensure and celebrate co-production and collaboration on solutions, keep providing feedback and improvement, listening to lived experience, not just multiple choice questions, and ensuring actions show that people have been listened to and learning is actually taking place as much as possible. For the second category for workforce with regards to choice, I'll read the statement out again. All staff in health and social care organisations as a minimum have at least level 2 dementia awareness training, which is really important to enable choice. Workforce development should include learning from the lived experience of a range of people living with dementia and their carers and families. The actions to support this included mandatory requirements for evidence-based of learning, and making sure that people took time out as part of their learning to actually go in and work with and take care of people living with dementia. We've got Health Watch Enter and View, to include people with dementia and carers as volunteers, I think down here as well, and encourage rehabilitation as a way of looking at dementia care and quality of life to improve choice. For DCAN here, we've got for DCAN to continue to act as a collaborative umbrella and to help health and social care organisations to come together a little bit more. I'll move on to the last point here. For systems with regards to choice, we have all through my dementia journey, I have access to an appropriate range of sufficiently funded services that recognise my personal needs and a clear pathway so I can make choices in advance and as I progress throughout my journey. To support this, actions include provision of information, but not just leaflets, videos using assistive technology, providing the opportunities to ask questions about it, increased government funding, more opportunities to connect and learn from people with lived experience. And for DCAN, obviously it's continuing to provide the opportunities for people with lived experience to contribute and inform the development of this, and also turning up the volume, sort of raising the visibility of the voices of people affected by dementia as well. So, thank you.
Okay, hi. Our lovely table looked at shared decision making and considered what does really good shared decision making look like for a person with dementia and their carer. And we explored some of those tricky issues around how do we make sure that carers are involved in decisions that affect the health and care of a person with dementia, but equally how do we ensure that clinicians are confident to include carers and that the carer isn't taken over and that they have the best interest of the person at heart. So it's quite a tricky issue. We felt that DCAN would have a role in identifying what that good practice really looks like and sharing that. One of our main things that I think we want to share with you all is GPs having the skills and confidence and knowledge to have that really tricky conversation, that really good conversation with a person and their carer at diagnosis. And we felt that although GPs have a great amount of skills, that was an area that needed more attention. But in the interest of brevity, I will leave it there.
Last but not least.
Okay, we'll also be brief. So our task was to think about supported self-management. And I'm not going to read out the individualised statements, but the thing that glued them together came back to something we've heard from the beginning today. That in order for people to assume self-management, they have to feel and be accorded agency in their own lives. So this principle of being at the centre of their own lives, a common experience was being robbed of that feeling and that role very early on after diagnosis. So that needs to be reaffirmed. But also that we need to think wider than the health and care systems, because successful self-management means living in a society that is more generally inclusive and supportive of people with dementia. So these bigger agendas of dementia-friendly communities, the Equality Act, what wasn't mentioned earlier, and the work the Alzheimer's Society have done linking dementia to disability, all very relevant to achieving these goals. Now, Ian's not going to believe that I didn't lead the table to this, but one of the most significant things that came up all the way through was the need to tackle stigma and misconceptions about dementia, and a need to change the narrative. That the narrative isn't one that kind of infuses people with a sense of hope and possibility and a sense that they can change their own lives. Quite the opposite. Much of the narrative is one that suggests that dementia is tantamount to a death sentence or to incoming decline. So there's a need to reverse that narrative, and we think that DCAN could play a role not in mounting a campaign of equivalent to time to change. That would be a bit ambitious, but it's certainly catalysing the need to address stigma as being absolutely central to this agenda of shifting a degree of control to people with dementia, changes in power and so on. But there needs to be a concerted campaign. So catalysing action, perhaps kickstarting the research that would be necessary to do that. Related to that, we think there'd be a real advantage in making an effort to grow peer support. We see things like the Deep Network, there are other peer support groups around the country. How can DCAN help share their stories, give them greater profile, connect them together, offer them the technical assistance they may need or new groups might need to evolve and develop over time. So we think peer support is absolutely key. And interestingly, from my own background, understanding where direct payments were successful, they directly correlated whether there were really strong peer support groups of disabled people, centres for independent living locally. That's where direct payments really work. So there's a direct relationship between this agenda and connecting people together. And finally, a lot of other people have mentioned it, but the whole issue of workforce awareness, training and development. A couple of issues here. One, can we work towards the idea that all training must at least be co-led by somebody with dementia? So again, bringing back this issue of peer support, people co-production, people being involved in the rollout of that training. How could DCAN try and influence various other organisations to pursue that? There were questions raised about standardisation of training, a sense that standardisation does exist, but it's not necessarily promoted or understood, so that some hospitals implement training that's just locally developed, or for that matter, the Alzheimer's Society offers training and it doesn't mention the standard on the website and things. So understanding where these standards play in. But also, how do we incentivise the take-up and rollout of training? These standards might exist, these courses might be there, but are they actually being implemented on the ground? Is there anything more could be done to influence the regulator in terms of CQC ratings and the links back to training, or kite marks, sorry, I'm making these things up now, or kite marks and things like that. But we did talk about we began to talk about how you would incentivise that in practice. So in a way, we sort of think the clue to self-management really is culture change first, because fundamentally, if we're going to believe people can assume that degree of control and actually instill in them that belief, then we need to tackle the stigma, change the perception of who people with dementia are and their seat around the table.
Brilliant. Thank you very much. Okay, I'm conscious that I failed in my task of getting you away on time. We're 2 minutes past time, but that is all the work done. The last thing I want to say is, on your table, please make sure you've written a pledge down. If you've written a pledge down, don't take it away, because we'd like to see them. Please leave it on the table. If you need to make a note of it, take a photo, put it in your diary, whatever works for you, to remember what you have said you were going to do. But please leave them on the table. Please also leave on the table your slip about the playlist, the song, the music, because we will be pulling together a playlist. One of the questions that I've been asked is, can we have copies of tables from the notes from the tables, even tables from the notes? I've lost it now. Yes, of course, I'm saying yes because it's not me typing it up, but I absolutely think it's really important that we get to see all of this pulled together into what will probably be more than one page, but we'll definitely be pulling all of the work together. There are some feedback sheets on the table. If you feel so inclined and have time to fill one in, please do that. And the last thing to say is thank you so much for working so hard today, and I wish you all a very safe journey home. Okay, thank you. Oh, that was my last bell. You could go. That's like the end of school bell.